gonna start. So, good morning, everyone, and thank you for joining us today in another international rounds. And it's my great pleasure today to introduce Dominique Vervoort, who is the president of the Global Surgery Initiative and one of the founders of the association. Is an advisor of the Global Surgery Foundation, and we have now the luck and the luxury of having him as a PhD student in the University of Toronto. Dominique is well known because his defense of the global cardiac surgery, and he's gonna just discuss today the approach of congenital heart disease at the heart of global cardiac surgery. So, Dominique, thank you for joining us today, and the floor is yours.
Great. Thank you so much, Dr. Alonso, and thank you everybody for joining as well. It's a great honor to be here and speaking about a topic that's very near and dear to my heart, being the topic of congenital heart disease, and then specifically within the context of global cardiac surgery, trying to frame both areas through the lens of each other. I have nothing to disclose, but I do want to start off with a very grim number, and that is that 6 billion people currently lack access to safe, timely, and affordable cardiac surgical care worldwide. And the reason for that is multifactorial. And so this is why I want to kind of dive through a couple of topics before ending on a bit of a hopeful note, just to say that in recent years, things have been advancing and there might be some hope for the future as well. But I want to start off with the field of global surgery first, just because I think it's important to know what the broader disparities are before we're talking about something as niche as global cardiac surgery, pediatric cardiac surgery, and pediatric cardiovascular care more broadly within the context of global health. Now, from a surgery perspective, we go back to 1980 when Dr. Halfdan Mahler, at the time Director General or the Chief of the World Health Organization, was the first to talk about access to surgery or lack of access thereto as a social inequity within healthcare, and the lack of access being that serious manifestation thereof. Now, when Dr. Mahler at the time spoke about this, he was speaking to a bunch of surgeons. And so obviously he was preaching to the choir, and it really didn't extend beyond that. And so besides this moral call to action, we have to fast forward to almost 30 years later to really see something else happening. Now, in 2008, Dr. Paul Farmer unfortunately recently passed away, and Dr. Jim Kim, both of them were at the time infectious disease specialists at Harvard Medical School. Dr. Paul Farmer went on to pursue his work with Partners in Health, which he founded, and Dr. Jim Kim became the president of the World Bank. And so both were very renowned within the field of global health, but both were not surgeons. And yet they published this paper, this commentary, or this editorial on surgery within the context of global health, coining surgery as the neglected stepchild of global health. And so when Dr. Paul Farmer was asked, why do you as an infectious disease specialist care about surgery when it has nothing to do directly with infectious disease? His answer was simple. It doesn't matter if we invest in infectious diseases, it doesn't matter if we distribute antibiotics, mosquito nets, and so forth. If the next day a patient goes out on the street, gets hit by a car, doesn't have access to trauma surgery, and then passes away. And so this was a good way of looking at global health through a health systems perspective as opposed to individual disease silos. Now, 2015 for global surgery was really the golden year because of these three documents. On the left was a document by the World Bank, was a series of volumes dedicated to different areas of healthcare, looking at what is the burden of disease, but then specifically what are cost-effective interventions to address that burden of disease. And this was the first time that the World Bank in this series, the Disease Control Priorities 3, which was the third edition of this series, addressed surgery. And they didn't just address surgery, but they addressed it as the very first volume of the series. In the middle, you see the Lancet Commission on Global Surgery, which was a global expert panel of surgeons, obstetricians, anesthesiologists, epidemiologists, health economists, and so forth, who came together to really quantify what access to surgical care looked like globally. And I'll show some of those numbers in just a second. But then on the right as well, very influential, on May 26, 2015, the resolution WHA 68.15 was adopted by the World Health Organization, and all 194 member states or ministries of health affiliated with the WHO adopted this to firmly and for the first time ever state from a political perspective, surgery and anesthesia are a component of universal health coverage and thus are a component of global health. And so this was really pivotal. And the reason for that is clear. The Lancet Commission has showed us that 5 billion people lack access to surgical healthcare when needed. And as a result, 18 million people currently die due to lack of access to surgical care. These 18 million people, these 18 million deaths every year could have been prevented with access to surgery. And when we look at this burden, that's more than 5 times as many people die as from HIV, TB, and malaria combined. And yet, very few people within the context of global health still talk about surgery, and the majority of attention is still towards infectious diseases. Now, that does not mean that we don't have to address other areas of healthcare, but it also means that we can't forget about what the burden is. And so also for people living with conditions, those people who aren't dying but are living with disability due to surgically treatable conditions, 1/3 of the global burden of disease is currently amenable to surgery. Now, when we talk about access to care, when we talk about the 5 billion for surgery or the 6 billion for cardiac surgery, which obviously has greater layers of access to care and complexity thereof, we talk about not just geographical accessibility. We're not talking about the fact that, okay, we go out and we have to walk or drive or fly to the nearest hospital, but we're also talking about capacity. Is that hospital capable of providing surgical care? Is the infrastructure there? Are the resources all the way to even simple surgical sutures available, but also things like critical care capacity, blood banks, and so forth, which are of importance for especially pediatric cardiac care. In terms of a quality perspective, the third layer, we have to ensure that if surgical care is being provided, it also has to be of high quality. We can't have patients die just simply because of a lack of quality, because then there really isn't access to care. And then arguably most importantly and lastly is the affordability component. Are patients able to afford surgical care, or do they have the means of affording a true health insurance, or are they being pushed into poverty or further into poverty just simply because having to pay for it out of pocket? And the affordability component is specifically for surgery and by extension cardiac surgery, the biggest barrier still all across the globe. Now, when I talk about these disparities, I do want to note that especially from a surgery perspective, there has been some momentum since that golden year, since 2015, both at the local level with governments, with ministries of health developing policy plans dedicated to scaling surgical healthcare, which are called National Surgical Obstetric and Anesthesia Plans, but also internationally with the WHO, the United Nations Institute for Training and Research, and the Global Surgery Foundation supporting all of this. And so we could arguably say that surgical healthcare is no longer a neglected stepchild, but there remains still much to do. Now, I want to talk about the field of global cardiac surgery just because this is the bulk of the conversation, and this is also why I hope that you're all here for, and trying to emphasize that or trying to frame that through the lens of congenital heart disease. We have to go back not as long ago as the field of global surgery, about 20 years ago, when Dr. James Cox, at the time president of the American Association of Thoracic Surgery, was the first to present on global inequities within access to care. And he was the first to talk about this, but mostly through anecdotal perspective. His data were mostly from a survey and were really limited in terms of the messaging that it provided, just because there was really not much known at the time. Now, a few years later, Dr. Rodolfo Neirati was the first to quantify based on this survey and estimated about 93% of people in low and middle income countries lacked access to cardiac surgery, which at today's population would be about 6 billion people. Now, the field of global cardiac surgery was previously undefined, and so we really have to define this to really be able to talk about this. And the field of global cardiac surgery isn't just what we see within the operating room, isn't just about the surgeons and being able to provide surgical care, but also providing every aspect of access to care, all the way from community detection, all the way to follow-up care, and so forth and so forth. Now, the field of global cardiac surgery has been set back due to a variety of reasons, and that includes that there has been supposedly no role for interventional cardiology or cardiac surgery within global health, despite the fact that the disease burden is so high. It's been said that it cannot be scaled or cannot be even introduced, and that it is supposedly a luxury, and yet many low and middle income countries have high and very efficient and high quality centers that are providing even low cost and free cardiac surgery to their patients. and also that is supposedly an isolated intervention. Yet when we look at what is needed for cardiac surgical care, we really see that there's a bunch of spillover effects for other aspects of the healthcare system. When we look then specifically about the disease burden, there are three major areas of cardiovascular care that are of prominence within global cardiac surgery. One being rheumatic heart disease, which in high-income countries like Canada is largely eradicated apart from indigenous populations and marginalized populations, but globally still affecting over 30 to 40 million people worldwide. Only 1 in 10 people who require surgery, unfortunately, are operated on. Ischemic heart disease, we're all very well aware that ischemic heart disease is a leading cause of morbidity and mortality due to cardiovascular disease, and is especially also affecting lower and middle income countries, increasingly so due to their transition away from infectious diseases and towards non-communicable diseases, and also affecting them at younger ages compared to high income countries, meaning that patients are being affected during the time where they're still contributing to the economy where they are, still generating income for their families, and really at a time where it's affecting them the hardest, and where it's affecting economies at large and socioeconomic development at large the hardest. And then lastly, and specifically for this talk, most importantly, congenital heart disease are the most common major congenital anomaly. It's affecting 1 in 100 babies, and it's estimated about 1 in 2 will eventually require surgical or interventional care, despite the fact that a majority will require some form of care, whether medical or interventional or surgical, within the first year of life. Over 90% is left untreated. And we estimated recently that about 200,000 children with congenital heart defects die every year and could have been saved if comprehensive pediatric cardiac care would have been available. Now, this gives you a bit of a perspective of what the current burden looks like globally, and you see the figure here on the right that is pertaining to the mortality rate specifically for infants then. But when we look at it overall and we look at the prevalence, the DALI, so the disability, we see that it's very similar. And that means that the more red, the orange and red areas are the ones that are most affected. They have higher rates of mortality, they have higher rates of morbidity, and that is due to the fact that there is less care available. And we see areas like Canada, most of the US, Europe, etc., that are largely low in terms of their mortality rate and morbidity rate, with some variation also within the countries. However, when we look at it globally, 260,000 people still die every year due to congenital heart disease. 180,000 of those are below first year of life, which is largely a result due to access of care, especially considering that most deaths are occurring in low to middle SDI quintiles, so countries that are defined by their socio-demographic development, which in other cases is also converted or defined as low and middle income country, but here further quantified in terms of further socioeconomic metrics. Now, the disease control priorities, as I earlier showed in 2015, was the first time that they included surgery within their series. And within that series, when we delve deeper in terms of their mention of access to surgery and the global burden of disease, we see that they also quantify it for congenital heart disease specifically. And they found that for the disease groups that they looked at, which were the ones that they considered the most amenable to surgery, the largest number was actually due to congenital heart defects, with about 66% of those. And also the majority of that vertebral burden that they defined from scaling up specifically surgical care would have been allocated to congenital heart disease. And so this kind of goes to show that the large burden globally is largely excess, and a large share of that burden is amenable to surgery and could be averted if access to surgical care, and by extension, broader pediatric cardiac care would be available. Now, when we look at it in the context of the broader mortality rate from all causes, because you might say, okay, well, this is important, but diarrheal diseases are still taking place, HIV, malaria, other infectious diseases, and so forth. And that is very true. However, when we look at it globally, we see that investments in recent decades, improvements in overall sanitation, attention for infectious diseases, have all resulted in a gradually reduced under 5 mortality rate from a variety of causes between 1990 and today, and also projected in the coming years. But the incidence of congenital heart disease is largely stable across the globe, and is because of that becoming gradually more prominent globally, especially considering the fact that there's very limited attention for congenital heart disease. And so we recently quantified, as I mentioned, that about 200,000 children, or close to 200,000 children, die every year and could have been saved. And that means that about 90% or over 90% of global congenital heart disease deaths and disability due to congenital heart disease in children would be accessed and could be averted if comprehensive care is available for all. And there is some discrepancy when we look at it in the broader context. And again, I want to emphasize, we are not trying to take away resources from other areas of healthcare, but we cannot forget about what the burden is and really what are the areas of healthcare that are forgotten. You see on the right, the three right are current global health priorities: TB, HIV/AIDS, malaria, which have large burdens that are gradually declining. When you see at the bottom in terms of research attention, the research attention is vast. And also in terms of funding, roughly half of global health funding is allocated to just these three conditions. When we put that in perspective, congenital heart disease, yes, has a lower disability burden, just simply because of the fact that relative to TB, HIV, and malaria, it's less prevalent, but per burden or per individual living with congenital heart disease, the burden is very high, specifically so in low and middle income countries. And so while we see a decline, this is largely driven by improvements in care in high income countries. And the research, which is far less than that for these three conditions, is relatively large for cardiovascular conditions, but again, is largely driven by high income countries and really skews that perspective of disparities. However, what I think illustrates it best is that from the funding, global health funding, less than 2% is dedicated to all non-communicable diseases. And so a very, very small share of that is then dedicated to congenital heart disease. And so there really is that discrepancy in attention, despite the fact that the burden is so large. And as you'll see in the next few slides, access to care is even poorer. Now, more and more people are living with adult congenital heart disease, as you see on the right, and that is largely a result of earlier detection of CHDs, treatment thereof, especially in high-income countries, resulting in the fact that in high-income countries, the majority of people born with congenital heart disease now live into adulthood. And this study is also the image that I showed a few slides earlier, has shown that the burden, that the prevalence of adult congenital heart disease has not just been growing, but it's been estimated that over 90% of children who are born with it actually eventually survive into adulthood in high-income countries. However, we do not see that in low and middle-income countries yet. And so this is where access to care comes into play. Access to care is really much more than what we currently think about. It's much more than just getting a patient into the hospital and operating on them or providing the care that they need. It's really also providing the infrastructure in the workforce, being able to provide quality of care in a high volume manner so that everybody's able to access it, ensuring that financing is available at the systems level as well as the individual patient level, and ensuring that outcomes, treatment interventions, and so forth are gradually being improved through monitoring and evaluation thereof. Now, access to care, as I mentioned earlier, has different components, and it's no less with cardiac surgery, where from accessibility perspective, centers are really inequitably distributed all across the globe. Sub-Saharan Africa has about 1 center per 33 million people, whereas Asia has 1 per 16 million people. To put it in perspective, North America has 1 per 120,000 people, a really vast disparity. Similarly so, in terms of cardiac surgeons, high-income countries have about 140 to 180 times as many cardiac surgeons as low-income countries, and I'll show in the next slide how that is geospatially distributed. Thirdly, in terms of quality, various low and middle-income country centers are actually performing outcomes or achieving outcomes that are similar, in some cases even better than many high-income country centers, going to show that providing cardiac surgery in low resource settings is really feasible and is not something that we can forget about. And then lastly, the affordability component, as I mentioned, it's a very critical component, especially with something as costly as cardiac surgery, where cardiac surgery can be performed as little as $1,500 in, for example, India for CABG, in Vietnam at $2,000 to $3,000, in Nigeria and Ghana at between $5,000 and $8,000. And it's really limited when we compare that to Europe and Canada with many tens of thousands of dollars, and in the United States of America with over $100,000 per patient. And so costs can really greatly be reduced, but we have to recognize that without financial risk protection, without health insurance, without somebody covering those costs for the patient, most patients will not be able to afford that. So as I mentioned, the cardiac surgery workforce is unevenly distributed, and you see here the darker areas that have a higher density of cardiac surgeons for the adult population and adult cardiac surgeons to the left, where we see a disparity between high-income countries with 7 surgeons per million people and low-income countries at about 0.04 per million people. And to the right, in terms of pediatric population per million pediatric people, per million children or pediatric patients, about 0.07 pediatric surgeons in low-income countries and 9.5 in high-income countries. Again, a vast disparity. And it is no different for ACHD care, and it's largely given the fact that most patients in lower middle income countries with CHDs don't survive into adulthood, and so adult congenital heart disease care is really something that is not as much talked about. And when we look at the distribution of centers relative to the population, we really see that it's high-income countries and a select few upper middle-income countries that have some capacity or sufficient capacity for ACHD. But the majority of lower middle-income countries really do not, and is something that also has to be recognized as CHD care is gradually improved over time. Now, the current global volume or global surgical volume is also largely driven by NGOs, especially so from a CHD perspective. We recently quantified that about 86 NGOs are currently providing surgical or other forms of care for patients living with cardiovascular diseases worldwide. And the majority of those, about 81 of the 86, are providing care for congenital heart disease, 56 dedicated to pediatrics and 25 doing both adult and pediatrics. But they're performing only, and I'm saying only between quotation marks because it's still a considerable number, only 82 operations per year per NGO. Now, all of this together is a considerable number. It's about 10,000 procedures per year across these NGOs. However, when we look at it at a global level, at what is really needed globally, we really see that this is only a splash in the water. And it's really important for local capacity to flourish and develop so that eventually NGOs can withdraw and really are not necessary anymore within the context of global health. However, it has to be recognized that many of these NGOs are also supporting true capacity building, resource supplies, and so forth and so forth. And so these NGOs are also pivotal, not just through direct clinical care, but also through other means as well. Now, COVID, unfortunately, has had an enormous impact on global access to care, especially for patients having to be treated abroad and having to fly to other countries because they don't have access to care in their own countries, but also NGOs unable to go to specific countries due to restrictions, due to border closures, due to uncertainty with regards to the quality of care is being provided, due to uncertainty of outcomes with COVID-19 and so forth. And so this is an additional backlog that we have to address in the coming years. Now, for policymakers, all of this is great. Like, we know now what the burden is. We know really what the lack of access to care is. But if I'm a policymaker, I also care about money. I care about allocating the money in the right way and making sure that the investments that we do for our health system are as efficient as possible. And this is where a metric like cost effectiveness comes in, where we are considering or thinking about what are the costs needed for a specific intervention, not just in terms of absolute numbers, how expensive something is, but also how that kind of comes into play relative to the disability that is being addressed. Now, when we look at pediatric cardiac surgery, it's a very complex, it's a very costly intervention, and nobody will disagree with that. However, when we put that against the disease burden, given the fact that patients with CHDs are very young, they're born with it, and so they still have an entire lifetime ahead of them, but also a big share of them will not survive if they do not get surgical care. And so if we put that cost of pediatric cardiac surgery against disability adjusted life years, the DALYs, or a measure of disability, we see that the costs are very low, about $171 per DALY. Put that against some global health interventions and global health priorities, we see that it's actually much more favorably cost effective than, for example, HIV/AIDS antiretrovirals, oral rehydration therapy for diarrhea, breastfeeding promotion, and so forth and so forth. Now, mind you, all of these conditions, all of these interventions, still very favorably cost effective, should still be done. But it also goes to show that there is a large misperception about the cost and the feasibility of cardiac surgery and pediatric cardiac surgery. Now, as much as it is good for countries to work together and for NGOs to support treating patients abroad, whether it's through philanthropy or through other means, such as the government supporting it, it's always better to do it locally. And a great example of that has been the country of Ghana, which has been a leader in terms of cardiac surgical care in West Africa, because they have been performing cardiac surgery for several decades, since the early 80s, but they gradually scaled their cardiac surgical capacity over time because of one big reason, and that was that the government realized that there was a discrepancy in cost between what they were doing at home versus what they were paying on sending patients abroad. Now, what they found was that when they were still sending a lot of patients abroad for care, it cost about $50,000 per patient to get cardiac surgery abroad. A considerable proportion of those were patients with congenital heart defects or rheumatic heart disease, whereas at the same time, patients being treated locally in their national cardiothoracic center in the capital were costing an average about $10,000 per patient. That is about $40,000 difference per patient. Over 100 patients a year, that's $4 million difference. That is money that could be invested into the local health system to treat patients closer to home, to ensure there's more job opportunities in the local health system so that other healthcare workers can also get a job and can also spill over services to other areas of healthcare. But also patients are treated in an environment that they know, with people who speak their language, with a culture that they're aware of, and they don't have to travel all across the globe to receive the care that they need. And so this is a great example of governments really making an impact in terms of access to care, and really why it's so important for countries and for governments to also recognize that at a local level, as opposed to just finding a stopgap solution by sending them abroad. Unfortunately, despite the fact, again, that we know the burden is large, the access to care is limited, cost effectiveness is favorable, there are economic arguments for investing locally, there remains very little political attention, both at the international level, which you see on the left, documents from the World Bank, from the WHO, the United Nations, with very limited language on cardiovascular diseases at large, very limited on surgery, even fewer on surgery for congenital heart disease, or cardiac surgical care at large, but unspecifically also for congenital heart disease. On the right, you see national political documents, which were the National Surgical Obstetric and Anesthesia plans, where at the time of analysis, 6 plans were released, and only one of those 6 talked about cardiac surgical care, and that was in Zambia, talking about what it costs to provide cardiac surgery, and really what should be done and what are the targets for the coming years. Most other countries, despite also having great disparities in terms of access to cardiac surgical care, did not talk about this. And so they were talking about different aspects of the surgical system, who were forgetting about addressing the thing that affects their largest disease burden, which are cardiovascular diseases and by extension, cardiovascular care. And we also see that largely at an international level for other conditions, not just for congenital heart disease or CVD more broadly, but also specifically for a disease that is very endemic in low and middle income countries still, such as rheumatic heart disease, where despite the fact that there is a socioeconomic argument for investing in surgical care for rheumatic heart disease, and thus for other cardiovascular conditions, given the overlapping infrastructure, there's very limited attention both at the national level and the international level, where cardiovascular care remains largely overlooked. Now, I want to close, as I said, with a bit of a hopeful note, just because I think that it's very grim to hear all of these numbers. It's very disencouraging to see what the current lack of access to care is all across the globe. But I have to state that much has happened in recent years due to a variety of different stakeholders and due to a variety of different accomplishments. Now, first example is the Cardiac Surgery Intersociety Alliance, which is an alliance or a collaboration between the major cardiac surgical societies and the World Heart Federation to specifically tackle the burden of rheumatic heart disease, which in itself is not directly affecting congenital heart disease, but of course, given the overlapping infrastructure and given the attention for cardiac surgical care within global health, will have spillover effects to talking about congenital heart disease in that context as well. The Alliance has been currently supporting 2 centers in low and middle income countries, the Maputo Heart Center in Mozambique, as well as King Faisal Hospital in Kigali in Rwanda, to grow in terms of their volume and support them through resources as well as through education to gradually grow and also eventually be able to increase their volume for other surgical conditions like congenital heart disease as well. Initiatives by trainees such as the Global Cardiac Surgery Initiative, which unites medical students, residents, and fellows interested in global cardiac surgery all across the globe, have come up, which creates a network of future global cardiac surgeons and global cardiovascular specialists, and perhaps even policymakers who are already connected from the get-go, so that there is a strong social network, but at the same time, there is a strong network in terms of advocacy and research dedicated to global cardiac surgery. From a policymaker and a patient family perspective, 2 notable organizations are the Global Surgery Foundation, which was incubated at the United Nations Institute for Training and Research and is based in Geneva as a neutral platform to support countries and governments in terms of their policy plans to improve access to surgical care. But also to support academics and academic institutions and industry to provide a central neutral platform to connect everybody in a way that improves efficiency within the field of global surgery. Now, notably, one of the 4 priorities of the Global Surgery Foundation is pediatric surgical care. And so the pediatric lens or the pediatric angle to global surgery is a big priority of the Global Surgery Foundation as well. Then Global ARCH, or the Global Alliance for Rheumatic and Congenital Hearts, might be an alliance that some of you are aware of, but it's an alliance of organizations all across the globe representing patients and families. And the goal of the alliance is really to provide a platform for including patients and families and their voice within the global health and global cardiac surgical dialogue. But also advocacy has been taking place at the level of NGOs, and this is an example of one NGO which has released a very influential series of advocacy documents to really paint a picture of what the global burden of disease is for congenital heart disease and what different stakeholders, whether policymakers, patient family organizations, healthcare professionals, etc., can do to help advocate for this. But also from a social media and online learning perspective, we have different platforms, or there are different platforms like podcasts, like conferences, like Twitter, to share information from conferences. Obviously, this international rounds and how that is being shared online, and educational platforms like Heart University and so forth, which are really providing greater access and greater opportunities for online learning and social connections as well, which eventually will greatly benefit global cardiovascular care. Also in the media, there is increasing interest of at least addressing some of these issues. And these are some examples of op-eds that have recently published on the issue of cardiovascular care, and in case of the right, also in terms of pediatric cardiac surgical care. And so it's really also important for the public and for policymakers to read it through the lens of the media, just simply because most of them will not open up an academic journal and read what the implications are of that. So it's really pivotal for us to translate it, not just within our academic communities, but also beyond them. Now, I also want to state that societies beyond the CSIA, beyond the Cardiac Surgery Intersociety Alliance, are also really moving the needle with regards to societal platforms and conference platforms for global cardiac surgery. To give you a bit of a perspective, before the pandemic, there was only one major conference, one major cardiac surgical conference that had included a global cardiac surgery session, which was the American Association for Thoracic Surgery conference in 2019 here in Toronto. But between October 2021 and upcoming May 2022, all major cardiac surgical societies, the European one, the two North American ones, the African one, and then also here locally, the Canadian one, have had or will have had global cardiac surgery dedicated sessions. This is an example of a trainee-led session on global cardiac surgery at the Canadian Cardiovascular Congress, which was led by medical students across Canada, and was really a great introduction for trainees on how to get involved with global cardiac surgery, but also to hear from global cardiac surgeons in Canada and in Ethiopia to hear what their experiences are with regards to global access to cardiac surgical care. The largest cardiac surgical meeting, the European one, had their first global cardiac surgery session in October in 2022, which I had the honor of co-moderate together with the president-elect at the time, now the president of the European Association of Cardiothoracic Surgery, and where we had speakers from all across the globe, from Nepal to Kenya, from Papua New Guinea to Colombia, call in to share their experiences with regards to global cardiac surgery, and was really a very important session, especially to illustrate societal interest and societal support for this topic. Also, the North American meetings with the recent STS and the upcoming AATS meetings have had or will have had global cardiac surgery sessions. And I'm showing you the program on the right, not because I require you to read through it, but just to illustrate that the AATS, which is a very large meeting, will not have just a session, but a 3-hour session dedicated to global cardiac surgery on the very first day of the meeting, which goes to show that the society is very supportive of it, but at the same time, members are really pushing for it as well, which is very encouraging to see how that is all growing. The African Association of Thoracic and Cardiovascular Surgeons recently had their normally annual conference, although this was the first one since 2019 due to the COVID-19 pandemic, of course. And they held this meeting together with the African Academy for Pediatric and Congenital Heart Surgery. And so this was their first joint meeting. And the meeting was not just dedicated to global cardiac surgery, which in itself is already very important, but it was also politically supported in the sense that both the Ministry of Health in Ivory Coast as well as the African Development Bank supported a meeting with opening words as well, which goes to show that we are kind of extending beyond preaching to the choir, but also piquing the interest of policymakers as well, which is really, really critical. Now, in terms of educational and research platforms, CTSNet is a very broad and very far-reaching platform that was set up by the societies specifically to make cardiothoracic surgical educational resources, whether it's videos, whether it's articles and so forth, open access available. And this is a website that everybody can access and doesn't have to pay for. But it also recently hosted a new topic on the platform, which is CTSNet Global, which is a new topic on the platform that is dedicated to sharing global cardiac surgery articles for free. And so everybody who has something to share can share it there, can submit it there, similar to in a journal where it's being peer reviewed, but if it's accepted, it gets accepted for free and it's open access for everybody to read. Now on the right, you see the NIH. The NIH is a large body in the US, which not only locally, but also increasingly so internationally funds research projects and has also recently gained an interest in specifically rheumatic heart disease. In November in 2021, there was a 3-day workshop for this dedicated to rheumatic heart disease, where after 6 months of planning, we connected with the public, and there were different working groups, both in terms of primary prevention, secondary prevention, tertiary prevention, and care, to really talk about what could be the funding priorities from the perspective of the NIH for rheumatic heart disease, for tackling rheumatic heart disease. And so the workshop series was really dedicated to have the expert working groups communicate with the public and really optimize those funding priorities. But what I think is most important is that the National Institute for Health and National Heart, Lung, and Blood Institute were showing, okay, we care about rheumatic heart disease, we care about global cardiac surgical care and global cardiovascular care. And that is really, really important, again, not just for the funding perspective, but also really to continue to introduce that point to the global health conversation. And so I want to close with the fact that we are living in a brave new world. We are living in a world where a lot is still virtual. We are obviously all virtual right now with the international rounds, but also many conferences are still taking place virtually or at least in a hybrid format. And in terms of surgical education, we've really learned how to leverage social media, how to leverage websites, how to leverage Zoom and online video conferencing to really optimize surgical education in the COVID-19 era, and hopefully also far beyond that, because these are some opportunities that we have to leverage, because it provides a more equitable platform for people to come together online, share their experiences, learn from the most recent literature and the most advanced techniques without having to go abroad, without having to obtain visas, without having to pay for travel costs and so forth, without leaving their home communities. And so I think this is a great example, and the international rounds are a great example of how we can leverage this brave new world, and hopefully something that we can do far beyond the COVID-19 pandemic. So with that, I want to close. I want to thank you again for kindly inviting me and for the opportunity to speak about this topic, and I'm happy to answer any questions that you may have.
So thank you, Dominic, for an amazing talk, an amazing review of the problem. So if anybody has any questions, just please feel free to type them on the chat or to just open your microphones and ask the question. So while people think about questions, I have some. So definitely you expose very well the problem, which is a problem that we should not ignore. But my question is, it seems that, or it's obvious that you have been investing in this for a long time, and you know the topic very well. But what can we do from a center like ours, for example, right? So we have one of the largest congenital heart disease centers, and how can we help to be part of this, or to improve access to cardiac surgery in congenital heart disease, which is what we do? What it would be our role in that bigger picture that is a worldwide picture to help even a little bit?
Yeah, that's thank you, Dr. Alonso. That's a great question, and it's a very important one. And I think the University of Toronto, similar to many other institutions, but just given that we're talking about the example of the center here, is a great example of an institution that's already been supporting it in a variety of ways. There's trainees, as I showed with the trainee session at the Canadian Congress, which was led by many trainees here at the University of Toronto. But also at the resident level, with some trainees being able to do rotations in low and middle income countries from a cardiac surgical care perspective to broaden their learning, but at the same time also bring some of their learning to their peers all across the globe. And at the same time, from a specialist care perspective, or from specialists themselves, with many surgeons here, but also cardiologists, also critical care specialists, also people in other non-cardiovascular areas, having long-term partnerships with institutions all across the globe and fostering that by either supporting capacity building through education, by going there and supporting either clinical care or capacity building through other means, but also in terms of, for example, these rounds where we are providing an opportunity for learning for everybody freely to access all across the globe. And these are some examples from a clinical perspective to really support this. Now, from, I guess, a bigger picture policy perspective, I think that the most direct entry point would really be supporting the research and supporting the knowledge of these gaps and of potential solutions with regards to access to cardiac surgical care. Because as I mentioned, the disparities are large, but some of these disparities are still very poorly quantified. Some of the solutions to define some of those disparities are very poorly quantified. And many policymakers are still very skeptical. Either they are not aware of these disparities, either they say, yes, this is true, but we don't know about this. or they're simply just not aware of it because they haven't heard about it. Nobody's talked to them about it. And it's really an opportunity for anybody, anywhere, to support the research perspective, but also to support it from an advocacy perspective and making sure that as many people as possible are aware of it, because that will eventually create a snowball effect that will make policymakers who are really making these decisions to become aware of it and actually start taking action.
So that's a very, very good answer. So yes, a more practical question. So if let's say that somebody is, I'm gonna say this, I'm gonna make this question on a personal level. So if I wanted to be involved on a practical, on the field, that's what just practically to help there to join one of these organizations, so just to provide my expertise, if any, in helping in this process. How can I practically get that? That's something that I personally myself would like to do, but I've never done it, just because I don't know what that would be the routes to get there.
Mm-hmm. Yeah, it's a great question as well. And I think the first entry point again would be the rounds themselves, which are a great example of how you're already involved and which are obviously leaving a huge mark all across the globe. But also secondly, I think I'm sure that everybody has their personal connections, either with individuals who are practicing elsewhere or with institutions, and really leveraging those partnerships and seeing how specifically in those partnerships you can further improve your involvement, just because I think it's very important for partnerships to be sustainable and to really benefit the work that we are doing. Just simply because hopping from one country to another, hopping from one center to another, hopping from one individual to another is really not leaving a big mark, just simply because there has to be that sustainability and that follow-up in terms of the work that we do, whether it's from an educational or from a clinical perspective. But then also secondly, and I think especially from an adult congenital heart disease perspective, it's still an area where there is still much to do. As I mentioned, access to care is very limited across the globe due to the fact that many patients are unfortunately not surviving into adulthood. And that's really an area whether you individually, the institution, or societies that you are involved with can support it by saying, okay, our society is acknowledging so many things, but is forgetting about adult congenital heart disease in a global context, or isn't talking about congenital heart disease in a global context, and so forth. And trying to either practically clinically involve through your personal partnerships, or from a bigger picture perspective, supporting it through societies and through your broader institution, are two examples that I think are probably the easiest way and the most impactful way to get involved.
Thank you very much. Candice?
Oh, okay. I was just going to say, first of all, thanks for the awesome talk. That was just fantastic, Dom. We really appreciate you speaking here with us today. But Rafa, I was just going to kind of go off what he had said. I mean, maybe it's something at the ACHD meetings that should become a focus, because we haven't really talked about global health issue or global health ACHD to a large extent, and maybe just like they've done at some of the surgical meetings, we should try and incorporate it, since you're partly responsible for running the ACHD meetings, as an example.
So when we had the North American conference that we held in Toronto, well, it was virtual in last year, we had one session that was just global health, dedicated to ACHD around the world. And just to give or to voice people, for people to have a platform to voice their concerns and local problems, which is, but you feel like a very little that you're doing something. You just offer, of course, you offer your platform and you a space, but sometimes I personally have the feeling that it doesn't make a massive difference. Of course, you have to have it there, but I was very impressed having a 3 hours session in the one that is happening in the surgical conference. That's probably what we need to move forward and to move towards, just to voice this more in the ACHD meetings.
I had one question though, Dom. I know you don't have too much time, but U of T has a big global health program, and I only know because I'm kind of involved from the pregnancy and heart disease perspective that they have a big presence at Moi University in Kenya. but do the different programs at U of T coordinate? So for instance, does U of T cardiac surgery coordinate with other programs that are already happening in global health that are pretty developed? Like,
Yeah,
do they centralize into one hub so that they can kind of concentrate what they can bring to a region?
Yeah, that's a good question. And before I forget, I'm going to quickly add to Dr. Alonso as well. I think even these small things are very influential, because as you gave the example, the 3-hour session are really a result of many people putting in small efforts, or putting in small things, or things that they perceive as being small, but really amount to something big. And that's why we're having these conversations. And it's similarly so, Dr. Silver cites, at an institutional level, it's really a result of individuals really pushing for this, having that personal interest, but also recognizing that these global disparities are there, and institutions can really provide potential support in terms of addressing this, whether it's directly clinically or through supporting by education, by research, by advocacy, and so forth. And the University of Toronto, just like many other institutions, have these institutional partnerships in a variety of clinical areas. You gave the example of Moi in Ghana. There was also an institutional partnership, or is in some clinical specialties with the hospital in Addis Ababa in Ethiopia. And I'm sure different centers in Toronto, different individuals might have their personal partnerships as well. So that kind of leads into my answer to say that unfortunately there's not as much coordination within an institution. And that's unfortunately the case everywhere, where because of a variety of reasons, because for example, okay, one specific clinical area is working in a given country, but they don't require support for the other given clinical area because they already have a partnership with another institution, requiring, for example, cardiac surgery to work somewhere else compared to, for example, the OB-GYN group, and similar for other clinical areas. And that leads to the fact that there is a lot of fragmentation, but also just simply because of the fact that there are different hoops to jump through with partnerships, whether it's regulatory on the ground, whether it's politically with people involved with the partnership, or the priorities of the local government or the local policymakers and the local decision makers, whether it's the institution themselves is driving it to one place or another, or even just a preference of the people involved. And so unfortunately, there could be improved coordination given the current lack thereof, and given the current fragmentation. And I think these kind of long-term partnerships, like for example in Moi as well as in Ethiopia, are some things that the University of Toronto really has to build upon and bring people together to ensure that that is coordinated, because eventually all of these partnerships will require resources, and it's best to optimize that as best as possible when these partnerships already exist.
So we have a question.
Yeah.
Sorry, Candice, go.
Oh, I was just going to say, like at Moi as an example, not only do they have people on the ground all the time, like OBGYNs, but they also now fund, U of T now funds fellowships to train trainees that to bring them up to kind of North American standards. So I just think there's a really strongly developed program, and it would be nice if things were coordinated because there's already resources and manpower in one spot. But
yeah, 100%.
Following that,
sorry, Raf, go ahead.
Following that comment, there's a question from David on the chat. Say, great talk, thank you. And I really like the example of Ghana. So global is good, local is better, and how they could save money and invest in their own healthcare system. So the question is, are there other low-income countries looking at to replicate the model, and how do you support them from the international societies or affiliations?
That's a fantastic question. And unfortunately, I can only give one example of a country that is projecting to do so. I'm sure, or at least I hope that there's more, but unfortunately, it's hard to know at the policymakers' perspective what their priorities are and what's really happening behind the scenes. But I gave a very brief example of national surgical plans, which are policy plans at the government level, where the government says, okay, we have to address surgery within our country. And these are policy plans that are long-term and are really important, because once they get funded, they will eventually have a big impact on access to surgical, obstetric, and anesthesia care. Now, as I mentioned, from the plans that have been launched, only one country has included cardiac surgical care, which was Zambia. And so they had just it as a one portion of it. But in terms of countries that are still developing it, there's one country, Papua New Guinea, whose plan is being led by the single cardiac surgeon that they have on the island. And the island is close to 10 million people. The cardiac surgeon is the only cardiac surgeon there, not just for the country, but for all Asia Pacific island states, which is a cumulative population of about 12 million people. And so he's leading this plan, but he also recognized that he, as a cardiac surgeon treating both adult and pediatric patients for 12 million people, cannot do this alone. And so he's framing this national surgical plan around access to cardiac surgical care, recognizing that there's spillover effects for other healthcare areas, but at the same time is also a really crucial thing that their health system is lacking and should address when they start implementing and start funding this plan. And so I think that is one example of another country that is doing it, and hopefully will be similarly effective as, for example, the country of Ghana has done. And now, how can societies and alliances support this? I think the answer is very similar to previously, and I apologize for that, in the sense that really starting to talk about it is really important. As I mentioned before the pandemic, there was only one session at a major international cardiac surgical conference on this topic. Now every single society has one, and that is very important, and is a result of many people being interested in and many people getting involved and staying and pushing pushing societies to say, okay, we have to address this, and this is also something for us to talk about. Even though we aren't living in those countries, it is still something we have to address, because this is affecting us all. And the current pandemic has shown us that healthcare anywhere is healthcare for everywhere, and for us all. And so we really have to consider everything from a global perspective. But it's also something that societies can really be supportive in, just like these international round societies are opening up more educational opportunities, with some of them also being openly accessible, so freely accessible, so that people from anywhere can get involved, to learn from what is happening, to learn from the latest research, to get context appropriate surgical education and so forth. And that is really how societies and alliance can further move the needle as well, to not just provide that support from a capacity building and research perspective, but also importantly start talking about this. Because if we don't start talking about this, policymakers are not going to start talking about this, because ultimately cardiovascular specialists are the experts who should be at the table to tell policymakers this is what is needed. But if cardiovascular specialists themselves aren't aware of it, if they're not at the table, if they're not telling policymakers this is what should be done, well, then nothing's going to happen. So I think it's all one big continuum, is something where all of us have a place to play, or a role to play. And I think it's important for us all to recognize that it's all interconnected as well.
Okay, so I think that on that comment, which is, I think, a perfect comment to wrap up, I think we have to finish here. So thank you everyone for joining us today, and thank you, Dominique, for a fantastic talk and make us aware of a big problem. And to all you that you join us, thank you for joining us today. Just want to mention that these rounds are now available on our website, which I just posted on the chat, and you will have the Dominique rounds available by Monday. And thank you again for joining us, and see you here in 2 weeks' time. And good morning, good afternoon, good evening, wherever you are in the world. Bye-bye, Dominique, and thank you very much again.
Thank you all. Bye-bye.